Are you ready to talk about what happens to your body in labor? I have props, I have a placenta. We're going to go through it. Now, everyone experiences labor a little bit differently and sometimes a lot differently. So, what we are going to do is go over the physiology and common sensations, as well as what may be happening around you as your midwife cares for you. Just a reminder that this video is about term labor, so after you are 37 weeks pregnant. If you think you are in labor before then, please reach out to your midwife. So, first, what is labor? Labor is a combination of strong, regular contractions and cervical change, so dilation and effacement. We need both of these components for you to be in labor. Sometimes your uterus can be crampy and contracty, but it isn't actually doing anything to your cervix. And sometimes your cervix is dilating and getting ready quietly on its own, but you don't have contractions yet. It really is the combination of the two that allows us to diagnose labor. The first stage of labor includes the latent, active, and transition phases. The second stage starts at full dilation, so 10 centimeters, and continues on until the birth of the baby. The third stage lasts from the birth of the baby to the birth of the placenta. And the fourth stage consists of the first hour postpartum. Part of the first stage of labor is early labor, or the latent phase. So this is when you're having contractions that are associated with very early cervical change, from a long closed cervix to one that is open about 4 to 5 centimeters. The thing about early labor is that it is not predictable. For some people, it may last a day or a couple of hours before you go into active labor. For some people, it may happen every night for a couple of days, but then go away for a while until your body is ready to have the baby. And other people skip it entirely and just go into rip-roaring labor right off the bat. Early labor can get your cervix ready for the big show. If this is your first baby, your cervix has to shorten and thin out first before it starts to dilate. If this is not your first baby, often it dilates a bit first and then shortens and thins out. You might have some bloody show, which is like a bit of spotting or bloody mucus. You might lose your mucus plug. That is all normal. You might notice that you have looser stools as your hormones change during this phase. These are all signs that your body is preparing and getting ready and changing, but it doesn't guarantee that you're going to go into active labor that night. For some people, this stage is longer than it is for others. One question that we get a lot is, what do you do if your water breaks? First of all, you need to figure out if your water has in fact broken. This happening before active labor starts only happens to about 8 to 10% of people, not exactly what the movies would have you believe. Often people mistake cervical discharge or urine for amniotic fluid. You can get a surprising amount of cervical discharge at the end of your pregnancy. Sometimes you may feel a little gush that wets your underwear. Sometimes you may let a little urine go because your pelvic floor muscles are a bit weaker than they used to be. If you think your water has broken, note the time and the color. If it is green or brown with meconium, please page your midwife, day or night. If it is clear, note the time and put on a pad. If you continue leaking and filling the pad, it is probably your water. If you wet the floor, it may also be your water. Take your temperature. Don't submerge yourself in a bath or put anything in your vagina. As long as your baby is moving like normal, the fluid is clear, and you don't have a temperature above 37.5 degrees, page your midwife during normal daylight hours. You can choose to induce your labor because the risk of infection increases as the membranes are ruptured for longer than 12 hours. However, one of the biggest factors in this risk of infection is the number of vaginal exams. So if you want to wait for your labor to start on its own, we refrain from doing them as much as possible until you are in labor. 70% of people will go into labor in the first 24 hours. 90% of people will go into labor within the first 48 hours of their waters breaking. Your midwife will make a plan with you to assess your baby and your vital signs if you choose to wait. So, how do you tell if you are in early labor versus active labor? The contractions in early labor may be irregular or not in a reliable pattern. So, they may come like every 3 minutes for 15 minutes, and then they space out to every 10 minutes, and then they go away for an hour. Then they come back when you stand up again, or they may be short, lasting about 20 seconds. Or they may feel mild, like a cramp in your lower belly. Or they just might be consistently every 10 minutes for the last 2 hours. The key to making your way through early labor is to ignore it for as long as possible and get as much rest as possible. Oxytocin, which is the hormone that causes uterine contractions, is a really shy hormone that does its best work when you are relaxed. Do not time your contractions until they take your breath away and you notice that they are picking up speed. You don't need to watch 10-minute apart contractions like a hawk. There's no point. Do low-key things you enjoy, like bake some cookies, watch your favorite movie, go for a relaxing walk, drink lots of water. A great early labor tool is a bath. Often, it will either quiet your uterus a bit and allow you to sleep, or it will relax you enough that the contractions pick up speed and help you ease into active labor. If you are having trouble sleeping because of early labor contractions, then you can take Gravol and Tylenol. One of my favorite tricks is to have my clients get into the bath and then take Gravol and Tylenol about 15 minutes before they get out. Then just tuck yourself into a nice warm bed out of the bath. Labor is a lot of work and you need your rest. You will not stop active labor with these tricks, but if you can sleep through your early labor, then you will have more energy when you really need it. I know you might have the urge to let everyone you love know the second you start having contractions, but honestly, try to keep this on a need-to-know basis. It can be really frustrating to get a whole bunch of "is the baby here yet" texts if your early labor contractions go away for a couple of days. In fact, it can actually stress you out enough that all those texts may cause the contractions to go away. Same thing goes with contacting your midwife. We are always there for you if you have an urgent concern or think that you need to be assessed, but we do not need a heads up page that you might be going into labor. We will just go like, okay, try having a bath. And you already know that now. Plus, if you page us at 3 a.m. with mild 7-minute apart contractions, then we won't be the most well-rested midwife that you need the next night when you may actually be in active labor. So I have my handy stuffed uterus here with his little smile to kind of show you the difference between what's happening with your uterus between early labor contractions that are preparing your body and active labor contractions that are causing cervical change at a regular rate. So Braxton Hicks are just kind of like just little uterine crampiness. They're not really doing anything. With early labor, you might feel them lower down in your uterus as they're like squeezing, and it's like it's an actual contraction, right? And it's just kind of affecting your cervix, which is down here, right? It's not actually having an impact on the top of the uterus at all. It's just getting things ready for you. And then as they get more intense, the entire uterus gets involved until you're in active labor and it's actually contracting really strong like this, and it's affecting the entire muscle as it brings your baby lower at a really regular rate. So think about the fact that your uterus is like right up underneath your ribs almost, right? That you're going to be feeling the contractions over your entire belly for a lot of people. Whereas with early labor, you might just feel them low and down here as they're working on your cervix. This leads me to the active phase of labor and when to page your midwife. So the active phase, in contrast to everything we just talked about, is predictable both in the contraction pattern and the cervical change it causes, and it does not stop until you have your baby. You can tell the difference because your contractions become longer and stronger and more regular. So in general, for a first baby, I want contractions to be every 4 minutes, lasting a minute, and for this pattern to be consistent for an hour, no matter how many baths you take. If you've had a baby before, I relax this rule a bit, but I still want you to have a pattern of good, strong contractions. When you are timing a contraction, you time from the start of one to the start of the next. And when you have this 411 pattern, then please page your midwife. They will call you back and listen to your story and assess your contraction pattern over the phone. Sometimes we have this magic trick where you were totally having contractions every 3 to 4 minutes before you called, and then we get on the phone with you and you don't have one for 8 minutes over the phone with us. We believe your story. This is just oxytocin being shy and telling us that your body's not quite ready for active labor yet. Your midwife will ask you to call back when they are a little bit stronger and more regular. If you sound like you are working hard with a good pattern of contractions, your midwife will offer to assess your cervix in person, because if you remember, we need good, strong contractions and a cervix that's about 5 centimeters dilated to diagnose active labor. How we assess a cervix is with a vaginal exam and our fingers. If you have never had a vaginal exam before, your midwife will go at your pace and will walk you through the process so you feel comfortable. If you are worried, you can ask your midwife to assess your cervix prenatally so that you know what a vaginal exam is like. Your midwife may offer to assess you at home or in the hospital labor assessment unit depending on your clinical history and birth plan. They will also listen to the baby, check your vital signs, and assess your contractions by feeling your belly. If you are not quite in active labor yet, your midwife will make a plan with you on how to keep you comfortable and when you should page back. If you are in active labor, you can be admitted to the hospital if that's where you are planning to have your baby, or if you are planning a home birth, they will stay with you and continue to monitor your labor. So, where is your cervix? What is your cervix? We're going to get our friend here to help us out again. So your cervix is actually the outlet to your uterus. And what we do is with our fingers, we actually measure the distance that it is open as well as the thickness and length. So if I think that this little ring here is the cervix and then this little plushy purple bit is the opening, how I would describe this cervix to a client is about 2 to 3 centimeters dilated. And I would say that's about 90% effaced or thinned out. We don't need a measuring tape. We don't need our eyes. We're very good at assessing all of that with just our fingers and a vaginal exam. The first phase of active labor goes from about 5 to 7 centimeters in dilation. For a first-time parent, I expect your cervix to change by at least 2 centimeters every 4 hours. If you've had babies before, I expect 2 centimeters of change every 2 hours. Your midwife will offer you vaginal exams every few hours to assess how your labor is progressing. During this stage, your baby comes lower into your pelvis. The next part is called transition. This is when you go from 7 to 10 centimeters in dilation. This is usually the most intense part of labor because your contractions pick up in speed and strength. Luckily, it usually causes your cervix to dilate a bit faster. This is the part where people often say they can't do it, but just know in the back of your brain that you are doing it and that this part is intense, but it won't last. Keep your rhythm. Sometimes people feel shaky or they go from hot to cold during this stage. Sometimes people vomit. It's a really normal pain response. I usually tell my clients that if you puke, it counts as 10 contractions. If your membranes are intact, this is the stage where they usually break on their own. So you've gone through transition, you made it to 10 centimeters dilated, which is considered full dilation. This is when the cervix is fully open around the baby's head, and this is when the second stage of labor starts, or better known as pushing. Your contractions are shorter and less frequent, which is nice because you get a bit of a breather in between. If you do not have an epidural, often you feel an urge to bear down or push, or you may feel rectal pressure like you need to have a large bowel movement. This is because your baby's head is pressing down on the same nerves that get stimulated when you need to have a bowel movement. Just go with it. That is a normal feeling. It does not mean that you are going to have a bowel movement, although you might. Your midwife is not just going to leave stool laying around. We get rid of it discreetly and we keep going. I promise you, I have been stooled on, I have been peed on, and I cannot remember what client did what. It does not matter. You need to use the same muscles to have your baby that you do when you are constipated and trying to have a bowel movement. In fact, if you do, it just tells me that you're pushing really well. So just let it all go and push. During this stage, the baby travels the rest of the way down through your vagina and kind of down in a J shape underneath your pubic bone. There are some breathing techniques that can help you push effectively. It is important not to breathe out all of your air when you push. You will give yourself some more power if you hold your air. I want you to think about when you were a kid swimming in a pool. Think about taking a big, deep breath of air and then trying to sink down to the bottom of the pool. You don't hold the air in your face because the pressure hurts. You send it down into your chest to help yourself sink lower. And that's what you need to do. Relax your legs, curl your chin to your chest, and send all of your power down and out. Then, after about 10 seconds, you come up just for enough air to fill your lungs again, and then you try to sink down even deeper. Your goal should be about 3 pushes like that with each contraction. Your support person can help you count. Sometimes it might feel like you are trying to squeeze a tube of toothpaste through a brick wall. Don't give up. You need to move your baby down centimeter by centimeter. You push with your contractions because then you have double the power. Take a break in between. Pushing is hard work. Your midwife may recommend switching positions to try and find the position that you are the most effective in. You can push on your back, holding your knees up. You can push on all fours. You can use a squatting bar on the bed. You can push lying on your side and your support person with holding one leg. It's a skill that you have to learn sometimes, and that's okay. Your midwife will help you figure it out. For a first-time parent, it's normal to push for up to 2 hours. Next babies are usually faster. When it's getting close for your baby to be born, we call the backup midwife. We need 2 midwives at each birth. As your baby is being born, your midwife will ask you to give teeny little pushes to ease their head over your perineum. Once the baby's head is born, your midwife will check for an umbilical cord wrapped around their neck. If it's there, and it often is, we just loop it around their head. And then the baby needs to turn to align their shoulders. This is called restitution. Sometimes with the same contraction, or sometimes with the next one, the body follows. We then bring them up to your belly where we dry them and stimulate them to cry. As long as they are well and you are well, we let the umbilical cord finish pulsing and then we clamp it and cut it. Sometimes partners can help catch the baby once the head is born, which is really, really cool. Or they can cut the umbilical cord. Talk to your midwife if this is something that you want to try and do. So a little demonstration of what your baby is actually doing when they're inside during labor. So they come into the pelvis. They have their chin tucked into their chest, nice and flexed like this, and they come down into your pelvis like this. Okay? So as you're pushing, it's bringing them lower and lower and lower and lower. And then you actually need to kind of swing them underneath your pubic bone right here. They need to kind of swing out like this, okay? And then you have these bones right here, which you can see, which kind of poke in, and sometimes those squeeze the baby's head a little bit, so sometimes we can hear them complain with their heart rate a little bit. If that's the case, we'll let you know when that's happening, and you really need to push hard to get them past that tight spot. And once you do, they usually stay out like this. And then you push and you push and you push, and the head is born, and then they align their shoulders like this. They turn. Your midwife will help with the top shoulder, and then will help with the bottom shoulder, and then the rest of the baby comes out like that. During labor, your midwife will be assessing your baby's position in your belly. And sometimes we can tell this before you go into labor as well. But if your midwife ever tells you that your baby is sunny side up or occiput posterior, it means that they're kind of hanging out with their back towards your back. And in comparison to the baby that I just showed you, right, you can see that their chin is not as well tucked into their chest, and they're just coming down with a larger presenting diameter. And then you can also see here, they're putting more pressure on your sacrum, right? So that's going to cause some back pain in labor, and it's also just harder for you to get them down and around your pubic bone, right? You can just see it's harder. So your midwife, if they're thinking this is happening, they might make you switch a whole bunch of positions to try and get your baby to swing around so that they're in a better position for you to be able to push out easily. The third stage of labor goes from the birth of the baby to the birth of the placenta. Your midwife will assess your bleeding during this stage. Sometimes it comes out quickly, other times we need to wait a few minutes. Breast or chest feeding your baby during this stage releases natural oxytocin and can help. You do need to push a bit, but the placenta has no bones and it's like giving birth to a large blob of jello, much easier than your baby. Most people feel a big release of pressure and much better after their placenta is no longer inside them. My favorite way that I've ever heard it described was like taking off a really tight ponytail at the end of a very long day. Once the placenta is delivered, your midwife will rub your uterus through your belly to make sure it is contracting nicely and check your vitals. They will then check your perineum to see if you need any suturing. Once this is done, we get you cleaned up and tucked into bed, and you're no longer pregnant. You get to focus on feeding both yourself and your baby while your midwives do a bunch of paperwork and keep an eye on both of your vital signs. Your midwives will stay with you for about 3 hours or so after the birth of your baby. This is my little plushy version of a baby in an amniotic sac with the placenta. So this is the side that is attached to your uterus, and yes, it is about that big. And then the baby is in the amniotic membranes containing the amniotic fluid here. So your water breaks, right? And they open up like this, and all the water comes out. And then your baby is born through the membranes like this. Okay, well, let's keep that cord attached like this with the umbilical cord. Okay, they're born, and then, and then the cord is clamped and cut, and then the uterus has to contract, and the placenta then shears off from the uterus, and it kind of comes out inside out as it's born with the cord and the membranes and the placenta organ. Okay, so that's kind of what it's like. So that, my friends, is kind of what to expect from a typical labor. Please talk to your midwives about your specific birth plan and clinical situation, and check out the links that I have in the description below.